Ideally, don't smoke. Smoking, the biggest problem with it in the mouth is it's the first place that the smoke hits. And it's a vasoconstrictor, so it constricts blood supply. And the one thing you definitely need, definitely in the healing phase, is you need a good blood supply. Now, I'm not naive. I've got patients who've looked me in the face and said, Doc, I definitely don't smoke. Definitely, definitely not. They forget that I can see the car park from my surgery window. And I see them in the car, roll the window down, and I see big plumes of smoke coming out. Yeah, don't do that. Smoking is, for me, a big no-no. Obviously, all the other stuff, take care of your health. Listen to your doctor. Diabetes is another one. If diabetes is down to your diet, if you want your implants to last, if you want your investment to last, change your diet. That would be my advice. But anything that you're doing that you know is causing self-harm to other bits of your body is definitely causing self-harm to your implants. Definitely. 100%.
Dave wants to know, my own dentist has always said that gum shrinkage takes full 6 months to fully normalize after tooth or teeth have been extracted. How do you deal with this? Because obviously the 21D process is much shorter.
Yes. So when I first started doing this, the standard understanding, because they didn't understand the biological processes like we understand it today, and I remember being taught this back in 1995, they said, take the teeth out, put the patient in a denture, let the gum shrink. What they actually meant was let huge amounts of bone loss occur, and then put the implants in. Yeah, this is complete nonsense. Complete and utter nonsense. If that's true, then why is it the vast majority of the world, and I'm talking very specifically about full arches today, the vast majority of clinicians in the world today will immediately load only? Because we know something. If you take a tooth out and you leave no load on the bone, or worse still, you put a denture on top of it, which is actually something that is actively destroying bone, you're going to be left with a lot less bone. Whereas if you take the tooth out, you clean the socket out and you set the parameters correctly, you clean the gum tissue and you put the implant in straight away, and you connect 3 or more implants together immediately, you actually don't lose anywhere near as much bone. So all I'd say is I'd question where he's getting that, what year the paper is that he read, where he's getting this information from. Because if he reads anything from 2024 about full mouth implants, it won't say what he's quoted. It will say the complete opposite of what he's quoted.
Sharon wants to know, are the top or bottom all on 4 got a full set screw on or piece by piece?
Full set. If I understand it, if you're asking me, is it a one-piece prosthetic? They're all one-piece prosthetic. So I'm sorry, I've got some here. Thanks for did you just steal it out of bioengineering? Did you tell them that we're taking this? They're going to go crazy tomorrow, right? Because they'll be looking for it's a demonstration set. So it's a one-piece prosthetic. So I hope you can all see this. So this is a titanium PMMA prosthesis for an upper jaw. Okay, it's a serious piece of engineering. And maybe, I don't think it's a bad idea if I do one of these out of bioengineering one day, just to show people how our milling machines and our 3D printers work. Would that be good, do you think?
So, absolutely.
Yeah, we'll do that. Okay. So they come in all kinds of different shapes and sizes for a reason. Everybody's different. And this is made for human specific. So you can't really leave these in a will because they're of no use to anyone other than you. So you just got to take them with you, right? But the point behind it is it's one-piece prosthetic because you get much better load distribution when it's in one piece. And actually, this, what we call the veneer part, which is the PMMA part, takes all the shock and dissipates the shock, dampens the shock. The bar, the titanium bar part, spreads the load over as much surface area as it can. And then by the time it gets to the implants, the force has been dampened, so it transmits up the implant at about the same frequency that stimulates healthy bone. So there is a lot of science behind this. So what we call it is the implant prosthetic bone complex. So it's not just the implant and the prosthesis, it's also the bone. Because it's actually the bone that does all the work, not this. This is just there to take the shock from what you're eating away, dissipate it, transmit it along the bar, and then up your implants to a level that's not going to damage the bone. So that's the rationale behind how we engineer these things. And obviously it's different for every single person depending on their own individual anatomy.
Leanne is saying, I've been told I have minimal bone on my top jaw and that I cannot have implants.
Okay. So minimal bone is a bit of a woolly statement. So the amount of bone we need is we need 4 millimeters in width, 8 millimeters in height, and we need it spread over an area in a curve across the front of about 40 millimeters, 4 centimeters. So if it wasn't measured, then we can't be sure. Okay, now they might be right. But if it wasn't measured, if they didn't quote things like we need 4 millimeters in width, 8 millimeters in height, and let me put that into context with what a healthy person with their own teeth would have at the beginning. They would have about 80, more than that, they'd probably have about 20 to 25 millimeters of bone in height. They'd have about 11 to 13 millimeters in width. So you'd have to lose a hell of a lot before you have virtually none. And even if you have, as they say, none, that's not always true. Then it's a question of the techniques that we're going to use. So one of the things I'll mention is we don't do zygomatics here. We don't do zygomatics here because I've done zygomatics and they do not fit the safety profile that I want for my patients. They go too close to the eyeball. I don't like that. They are very invasive. I don't like that. And the prosthetics end up, because they come out in the palate, the prosthetics end up quite bulky, which the patient has an absolute nightmare in adapting. And I will only consider zygomatics in the most extreme cases, but I don't need to, because I've got alternatives, like using pterygoids, which I started using back in 2007, which is even more biomechanically, much more biomechanically stable than a zygomatic. So why would I do zygomatics when I can do pterygoids? And no, I don't consider them a complex procedure. It depends on who you ask. If somebody's never done it before, then yeah, it's very complicated for them. But if you ask somebody who's done them for 15 years, it's not complicated at all. So we don't buy this complex nonsense that I hear from other clinics. There's no such thing.